Good morning, everyone. It is now going to be 9:45, and we need to start our session on comprehensive management of diabetic retinopathy. In this, we have a series of lectures which comprise systemic parameters and management of diabetic retinopathy, clinical presentation and classification, then diagnostic evaluation, lasers in diabetic macular edema and recurrences, and role of anti-VEGF agents and steroids in PDR as well as diabetic macular edema, and at the end we will be dealing with surgical management of diabetic retinopathy. With this, I invite Dr. Kim, Dr. Vishali, can you join me on the dais? Doesn't matter. Doesn't matter.
Whatever you
Yeah, because in early stages, we used to have only 5 people in the hall and we still managed it. This hall is very beautiful. That feedback should come, but the access is very, very poor. Unless someone is very oriented, can come over here, otherwise it's very difficult. Okay, we will start without any further delays. You can come over here, no problem. I invite Dr. Kim Ramasamy. He will be speaking on systemic parameters and their management in diabetic retinopathy.
Good morning, and thank you, Dr. Ajit, Babu, for this inviting me to be a part of this event. Diabetes, we all know, is there everywhere. Every other third, fourth, fifth person is diabetic when we are walking on the road. And today, the recent IDF has shown that the number is what we used to think as 470 million is 6.7 million, 537 million is the current prevalence of diabetes globally. Recent study done by the Smart India group, many multicentric study that was done in India, has given us the idea on what is the prevalence in India. India is supposed to be the capital of the world, and today we have a huge number. I won't go into the details, but 12.5% is the prevalence of diabetic retinopathy, retinopathy in the country. Coming to the topic on systemic parameters, what are the different parameters? We all know there are so many risk factors for diabetic retinopathy. Some are non-modifiable and there are modifiable factors. Modifiable is, as we all know, hyperglycemia, hypertension, dyslipidemia, obesity. And there are various other factors which we on a regular basis do not look forward to it. But there are enough evidence in the literature to show that why these, especially hyperglycemia, hypertension, nephropathy, all these are important in diabetic retinopathy. One of the most important things is the duration of diabetes, which is significantly a risk factor. The longer the patient has diabetes, more the chances of them developing any retinopathy. The higher frequency in gender, men seem to have a much higher prevalence over the female gender in the prevalence of diabetic retinopathy. In the recent Smart India study, it was also shown. We used to think that patients in the rural areas do not have as much a higher prevalence as the urban population, but it appears that it is almost similar whether you are in the rural or in the urban population. Glycemia, as we know, is the single most significant risk factor, which has been shown repeatedly in multiple multicentric studies, which have shown the importance of glycemic control. Even the Chennai, the CURE study by the Mohans group had shown every 2% elevation of HbA1c, the risk of diabetic retinopathy increases by a factor of 1.71. So there are, as I mentioned, multiple clinical trials have shown. Again, the Mohans group has shown the importance of following these patients with good control. The aim was to assess the relationship between the regularity of follow-up and the risk of complications in patients with type 2 diabetes who were followed for a period of 9 years, and it was found that the regular follow-up was associated with significantly lower glycemic burden and lower incidence of retinopathy and nephropathy over a period of 9 years. So it is very clear that these patients, if followed regularly for their systemic factor, would definitely benefit in controlling the diabetic retinopathy. The effect of glycemic control has been shown very clearly that even if a person controls the diabetes strictly within the normal limits, the chances of them developing diabetic retinopathy is 25%, but again, the chances of developing any severe retinopathy is much, much lower. Regarding hypertension, of course, it's proven that the tight blood pressure control reduces the diabetic retinopathy progression by 34%. And the ADA has recommended that the BP levels are kept within 130 by 80, should be aimed for people, especially with diabetic retinopathy, to reduce the burden of diabetic retinopathy. Serum lipids, again, another factor which we are all aware of, where the hard exudates, which we very often see, are often associated with diabetic macular edema, and the higher levels of cholesterol, or especially triglycerides, were associated with increased risk of these diabetic macular edema. Dr. Amod Gupta and the PGI team from Chandigarh have very clearly shown the role of oral atorvastatin in patients with type 2 diabetes with dyslipidemia. So many a times we do treat these patients, especially if they have a high cholesterol or high triglycerides, treat them before you even treat them with the anti-VEGF drugs in severe macular edema. Also in diabetic nephropathy, subjects with microalbuminuria were around 2 times as likely to have diabetic retinopathy than those without microalbuminuria. And especially when they have macroalbuminuria, the risk is almost 6 times. Pregnant women are more likely to develop retinopathy and have progression. And in women who begin pregnancy with no retinopathy, the risk of developing diabetic retinopathy is about 10%. And they should be counseled regarding the effect of pregnancy on the retinopathy for the diabetic women. All pregnant women with established diabetes should be screened in their first trimester for any evidence of diabetic retinopathy. And if they have any retinopathy, like severe retinopathy, it should be treated before the patient proceeds with the pregnancy. Anemia, again, individuals with anemia were 1.8 times more likely to develop diabetic retinopathy than individuals without retinopathy. In men, the risk of developing diabetic retinopathy increased to 2 times, but not so much in women. Anemia, as we know, is an independent risk factor for the progression of diabetic retinopathy. It promotes angiogenesis and worsens diabetic retinopathy. Very often, even diabetic, if you don't look for HB and the patient is anemic, they may have a lower HbA1c level, which will falsely indicate that the patient is under good control. Another important factor is the cardiac outcomes in patients with diabetic retinopathy. This overall 12-year overall survival rate for patients who undergo CAPG is 40% for diabetics with retinopathy compared with patients without retinopathy. It's almost double, 88%. So we did a study to understand the impact of diabetic retinopathy on the cardiac outcome after coronary artery bypass. It was an 18-month outcome study, prospective observational study. We looked at the fundus at the baseline before they went in for the presence of diabetic retinopathy at the baseline. And then the patient went through the entire process. But what it clearly showed was that diabetic patients who underwent diabetic retinopathy patients who underwent CAPG had more adverse cardiac events than those without retinopathy. It was very clear. Adverse cardiac events were reported in 65% of patients with diabetic retinopathy. So it can be, especially when you're treating a patient, when the patient with CAPG is, with diabetic retinopathy is going for a CAPG, they should be more carefully followed for problems related to cardiac issues. This is from Dr. Ajit Raman's group, how well in the DREAM study they've shown in the population, that only 34.4% of the diabetic patients have good glycemic control, 45% with systolic blood pressure control, and 60.6% with diastolic, and only 36% had a LDL control. So it really clearly shows that we are not there, the awareness is not there, and it's very important that this should be addressed on all these patients. And how often do we as ophthalmologists or as retina specialists talk to the physicians or to the diabetologists to ensure that the patient that we are treating is under control, or how often do we regularly monitor the diabetic? Every time you see it, are we taking a HbA1c level every 3 months or every 6 months at least? It's a big question mark. Very few people follow up on those patients very systematically, because literature clearly shows that you follow these patients on a regular basis and ensure a good control of all these systemic factors, the chances of these patients losing their vision to diabetic retinopathy is much less. So it is important for ophthalmologists to follow up on these systemic factors and collaborate with their physicians. Thank you.
You have time. This is the. Oh, yeah,
That's it.
You have time. Okay. Kim, thank you for highlighting all the factors. But can you tell about smoking, one, and use of phenofibrate? And these diabetics with anemia, they are resistant for improvement of hemoglobin. Hemoglobin with hematinics. That can you highlight?
Yeah, you have to correct, definitely anemic patients, you really have to correct their anemic status, because as I said, this also gives you a false factor that the HbA1c levels are lower and the patient is got under good control. So it has to be corrected. What is the other one you mentioned?
Phenofibrate.
Phenofibrate, yeah. Smoking is definitely a risk factor for diabetic retinopathy. In like many other conditions, definitely it has got a very high risk factor.
Yeah, in anemia particularly, what we should see is if they are not improving by hematinics, this could be because of renal origin, where treatment by erythropoietin is very much needed. So you need to indicate that either you assess the nephropathy status, whether it is it the reason for it or not, and then maybe refer to the nephrologist to look into it and then get it treated. Otherwise, anemia is a big risk factor. And okay, now myself will go and deal with clinical presentation and classification. You want to ask anything else?
No, I wanted to invite you, but you have invited yourself.
Can you put my slides on?
Can you put the slides? Dr.Ajit Babu. Title is Clinical Presentation and Classification.
No, it is there actually, but we have given. It is not good. This is not working.
Is it on that side? Which side where, Dr. Babu?
Good morning, everyone, and I would like to thank the Scientific Committee of AIOS for accepting our instruction course. This hall is a little bit difficult to approach, I know, but it's a good hall to have a discussion and have a presentation and session. As Dr. Kim highlighted that the prevalence of diabetes and diabetic retinopathy is very high. As such, in the whole global scenario, it is increasing, and in India, it is in a hot area. If you see that map, India is already in red. Can you? Right. When it comes to India and see what is the prevalence of diabetic retinopathy, we have among diabetics at least 1/3 will have some form of diabetic retinopathy. That's why this screening is very, very essential. And second, the incidence of PDR and DME is almost like 7%. So it's very, very common in all diabetics. And vision threatening diabetic retinopathy is almost about 10%. So everyone be well versed with diabetic retinopathy, especially when the patient diabetic walks into the clinic, you should manage yourself because every ophthalmologist should be ready to screen, and 90% of the diabetic retinopathy can be followed with general ophthalmologist. This point I want to highlight. It is not a retina specialty management strategy. And ETDRS has used this classic 7 fields for assessment and classification of diabetic retinopathy, which we will little bit highlight on it. And the macular grid is used to define yourself whether it is a significant macular edema or not. With the grid, different lines are there. The central 500 microns, and there is a dashed line which is 300 microns, and 1 disc area and 2 disc areas in this slide. But what is more important is diabetic retinopathy severity scale, which is an international classification, but ETDRS defined it a little bit differently than this. If you see here, if there are no apparent diabetic retinopathy, means there are no abnormalities are there. So if you do not find any signs of diabetic retinopathy, then you will say no apparent retinopathy. When it comes to mild non-proliferative diabetic retinopathy, it is microaneurysms alone are present, means there are absence of retinal hemorrhages, hot exudates, or any other signs like venous bleeding or IRMA. If it is moderate, means then it is microaneurysms plus the other non-proliferative changes are there. In that, we will go to the severe non-proliferative diabetic retinopathy, where you will see that at least the retinal hemorrhages should be more than 20 in 4 quadrants, or venous bleeding in 2 quadrants, or IRMA in 1 quadrant. These 3 are classic, but the importance of all these 3 we will tell you in more detail. Then any new vascularization is proliferative diabetic retinopathy. So when you see the clinical signs, you should look for microaneurysms, intraretinal hemorrhages, hard exudates, and cotton wool spots. Though cotton wool spots, we do not give so much importance in classifying diabetic retinopathy. These are, if you see the pictures here, there are very early changes of non-proliferative diabetic retinopathy, where microaneurysms are very few, and if you see the hemorrhages are also there. But if you see the red-free photographs, more or less, lot of signs they get highlighted. If you see the retinal hemorrhages, it's in ETDRS classification. It's very classically given example, standard photographs to classify whether it is mild retinal hemorrhages, moderate retinal hemorrhages, or severe retinal hemorrhages. And these 2 are, the first one is, the left one is mild, and that is moderate retinal hemorrhages, and severe retinal hemorrhages. Whenever you see more than 20, you can count actually, more than 20 retinal hemorrhages in a given quadrant, it is considered severe retinal hemorrhages. That is important in classifying diabetic retinopathy. Yeah. And there is some signs of, yeah, no problem. Then intraretinal microvascular abnormalities, similarly been classified as mild, moderate, and severe. Hard exudates also been classified as early and very standard of more severe hard exudates. Here you can see the hard exudates in this picture. As I told you, the color certain times masks the highlight the findings, but red-free really highlights the findings very well. Now we come why these three signs are important. One is 4-quadrant severe retinal hemorrhages, 2 quadrants venous bleeding, 1 quadrant IRMA. IRMA is very, very essential, and these three findings, if they are, one of them is present, it is classified as severe non-proliferative diabetic retinopathy. If more than 2 are present, any of the 2 of the 3, then it is called very severe. Why should we classify this in the clinic? This is the reason. If you see the severe retinopathy, non-proliferative diabetic retinopathy, the progression for PDR is very less, 15%, whereas in very severe non-proliferative, within 1 year, this patient's likely to develop proliferative changes. That's why it requires either a closer follow-up or you commit for treatment that we will later on discuss. And when there is a diabetic macular edema, again you should identify whether it is a mild, moderate or severe depending upon the retinal thickness and the hard exudate location from the center of the macula. And ETDRS has clearly defined this definition. Everyone knows that what is clinically significant macular edema. In this, what is more important is the retinal edema or the thickening. If retinal edema should be observed, if retinal edema is not there and hard exudates are present, then probably it is a responding diabetic macular edema. And with the advent of OCT, OCTA, and now we further classify the diabetic macular edema, which again in the management we will highlight why this classification is important. Then ischemic maculopathy should be identified in all the cases, you should not miss. And diabetic macular edema should also be knowingly different stages should be seen on OCT, and this is probably a more useful classification in typifying the diabetic macular edema on OCT, either focal thickening, diffuse non-cystoid or spongy macular thickening, diffuse cystoid thickening, again traction, either point traction or a diffuse traction, and serous retinal detachment on OCT. So ETDRS and the International Diabetic Retinopathy Classification, they differ by a very small whisker, but if you see the grades, mild, moderate, severe, and very severe non-proliferative diabetes. Till here, it is non-proliferative. Proliferative, again, it is, in general, it is called proliferative, but it is early proliferative, high-risk proliferative, or advanced proliferative diabetic retinopathy that need to be identified. How do you identify proliferative? Any neovascular development, you should consider this as a proliferative retinopathy. But once there is a fibrosis development, then it is high risk or more severe diabetic retinopathy, proliferative diabetic retinopathy. This is a little bit advanced case of proliferative diabetic retinopathy. And these cases may be associated with vitreous hemorrhage or a tractional retinal detachment, which again requires a management which is different from a regular photocoagulation. With this, I would almost close this presentation by saying that different steps are given. You need not follow all these steps. Like if you, the scoring on ETDRS, which is very, very complex actually. That's why I made it more simplified for you to understand in the clinic and then strategize your management. With this, I would like to conclude this. And if there are any questions, I'll answer.
Any questions?
Vishali, you can ask if they don't want to ask.
So, Dr. Babu, like you told us the ETDRS classification, mild, moderate, severe, 2-quadrant, 3 quadrants. In practice, do you actually do that?
Mostly I do. Because this is important, because whenever these patients come at the first visit, I always go for fundus photography. That is one standard practice which I would like to do, because nowadays we have the wide field fundus photograph, so it's less likely to miss the findings. Second, the advantage of wide field is we can enlarge and see how many actually the numbers are happening. And this will alert me first. And I will see whether this patient is available for a regular follow-up or not.
So wide field is an expensive camera, or ultra wide field. So what would you recommend for the general ophthalmologist? Because diabetes is no longer a
Yeah,
retina specialty. It has to go to the
Yes.
comprehensive.
We have cameras which are very, very economical, or even nowadays smartphone photography is another thing which you can have. Because what will happen is in your busy clinic, certain times you may not be able to screen it, all the fundus. So it's better to tell your assistant to take the photographs and then you reassess. That will help you much more in picking up and not missing the lesions. That is more important.
Thank you. Any questions for Dr.? Yes, please.
It's actually a doubt, Dr. Ajit. This IRMA, sometimes it becomes very difficult to diagnose and it changes the classification from non-site threatening to site threatening DR.
IRMA.
Yeah, it becomes
IRMA,
a severe
if it is
NPDR.
there, yes.
Yeah. So how do we get it between those hemorrhages?
Yeah,
Clinical tips.
that's why I always suggest you for a red-free photograph.
Between those spots, what is that which should tell me that no, this
It
is
will,
IRMA?
usually it also will not cross the vessels, but you should identify a vascular network from a hemorrhage. That by enlargement and red-free photograph, definitely you can identify. If you are still in doubt, it's better to have a angiography or
Yeah, thank you.
OCT. Dr. Brijesh, he is a retina specialist, so don't worry. He know how to assess, but he suggested, means wanted it that angiography should also be done in these cases if you are in very doubt.
Thank you. Thank you, Dr. Babu. Yeah.
I will invite. Okay, then we will move on to the next talk. That will be by Dr. Vishali Gupta, and she will be dealing with diagnostic evaluation in DME. That's why I didn't answer that question by Brijesh. She will answer that more efficiently.
Thank you, Dr. Babu. Dr. Babu is like my mentor, so it's really an honor to follow him. And I will be essentially talking whatever he is spoken about and talking about more of the diagnostic. So it's kind of a continuity in the talk. So he showed this very beautiful pictures that the patient might come to you with very early non-proliferative diabetic retinopathy. So you know it's very early. You really do not have to do any imaging other than fundus photography for the documentation. We move forward. The non-proliferative diabetic retinopathy is not very early. It's somewhere between mild to moderate, but still it's not severe. Again, the diagnosis is clinical, but at this point of the time, you should pay attention. Is there any associated macular edema or not? So to look at the macular edema, please don't try to look at the macular edema in the fundus photographs or the ultra-wide field photographs because you will likely to miss the macular edema. The way to look at the macular edema is a good stereoscopic clinical examination. There are criteria by ETDRS when to define macular edema, but in simple words, if you see the retinal thickening or you see these hard exudates, these are the monoocular clues that there is retinal thickening. So if you see something like this, you know there is macular edema. Sometimes the problem happens is there is a retinal thickening and you can make out, but many times you will not be sure whether there is macular edema or not. So that is the scenario when you would do OCT to look at the thickening. So when you do OCT, the aim is that your OCT scan, besides the graphs and the chart and the retinal thickness, it should pass through the center. If it is passing through the center, you would see whether it is center involving macular edema or it is non-center involving macular edema. Because if it is center involving diabetic macular edema, you've got to give anti-VEGF injection. If it is not involving the center, anti-VEGF is not required. So far it's just the clinical exam, fundus picture, and OCT. When you do OCT, Dr. Babu showed you, you will have different patterns of macular edema that you will see. Now, on the top, you see something like sponge-like thickness, as if the water has been, soaked by the sponge. So the whole retina becomes spongy. If it is a sponge-like thickness, go to the foveal scan. If it is center involving anti-VEGF, if it's not center involving, we will come to that subsequently. The second pattern is the cystoid macular edema. You see these large cysts, and you can see this is actually a time domain scan. So you don't need spectral swept sources to tell you there is macular edema. As a comprehensive ophthalmologist, whatever OCT you have is absolutely fine. So if you see cystoid macular edema, one thing for sure there is no laser for this patient. You need a good systemic control. You need to bring the thickness down, and that you can do with the help of anti-VEGF injections. If they don't work, then maybe steroids. The third pattern is serous detachment, and I have put the fundus picture on the sides because clinically they all look similar. So you don't have this classification based on the clinical exam. So if you see serous detachment, always get a renal profile done, because many of these patients may be having microalbuminuria, and ACE inhibitors and all do have a role. Treatment, serous detachment responds very beautifully to steroids, but I'm not saying you start it. Start on anti-VEGF steroids. It goes away very quickly, and get a good systemic control. Now comes the last part where you have the hyaloid, which is attached to the broad-based adhesion to the retina, which is called taut posterior hyaloid, or you may have a vitreomacular traction. If that is the case, these are the candidates which are neither for injection, they are nor for laser. Straight away you have to go to surgery. Now, the component which was left was that you have seen on OCT the edema is not involving the center, and you have decided that this patient needs focal laser. Now comes the role of angiogram. Angiogram is not required to make the diagnosis of macular edema. It is just required to look at the microaneurysms. You want to delineate the microaneurysms, and you want to see as to when would you, and you would like to see as to when would you like to treat them. For example, you want to target these microaneurysms by projecting the fluorescein angiogram in front of your laser so that you precisely treat the microaneurysms that are leaking in the late phase. Now, this is the role of the angiogram. Then you come to the severe NPDR, and severe NPDR criteria Dr. Babu has already told. I would just like to emphasize that once you see these venous bleeding, this bleeding and the loop, be very mindful of the fact that this is going to harbor some severe areas of capillary non-perfusion around it. So be very careful about doing the angiogram, because many of them would show very subtle new vascularization, which you may miss clinically. So at this point of time, you would need an angiogram to look and characterize that it is not early proliferative diabetic retinopathy. This is just to show you that the clinical picture, when you see the venous beading, venous loops, here you can see the venous beading, and you see there will always be areas of capillary non-perfusion and small new vascularization along with it. Dr. Babu has already told about advanced and how it has a risk of progressing. Now you see on the top, this look like severe NPDR. You do a fluorescein angiogram, you realize there is a whole lot of areas of capillary non-perfusion, which probably need to be managed because 50% of them are going to bleed in the next 1 year. And this is how it happens if you don't pay attention to very fine new vascularization on the disc, or you miss, or you ignore. 9 months later, the same patient will come to you with a huge bleed. So this is the borderline area where fluorescein plays a very important role in picking up the new vessels. And last component is proliferative, which essentially does not need much of diagnostic skills, but make sure to look at the disc. Don't be carried away with ultra wide field optos and all, because that gives a very poor image of the optic disc and of the macula. So key point for me personally, for comprehensive ophthalmologist, is not to miss the NVD and major NVEs. So you can't be focusing in the periphery and missing out on the disc. So always look at the disc with your stereoscopy, direct ophthalmoscope, or the standard images. And this is the fine NVD on the surface of the disc, as you can see. If you are seeing NVD angiography, honestly doesn't have a role, because it is just going to say that these new vessels are there, which are becoming hyper, but you are seeing them clinically as well. So these new vessels bleed. So if you see new vessels, you just start with the treatment without any angiograms. This is how they bleed. So this is showing the trickling of the blood from the new vessels to pre-retinal bleed. Pre-retinal bleed could also come from a small new vessel, and you may not be able to see those new vessels.
1 minute to conclude.
Yes, I'm almost done. But anytime you see a pre-retinal bleed or mild vitreous hemorrhage, it automatically means there are new vessels, so you can start with the treatment without waiting for angiography or anything. This question was asked, like sometimes there are subtle new vessels and you are confused between ARMA and new vessels. New vessels would be raised cogwheel-like, ARMAs would not be, but if you are in doubt, get an angiogram, new vessels would leak, ARMA will not. The last stage where it develops proliferative tabletop traction, you don't need any investigations except if there is a vitreous hemorrhage and you want to rule out, you may do ultrasound, otherwise there is absolutely no need to do. So last part is that when you are talking about imaging, it's very important to characterize diabetic retinopathy, mostly on what Dr. Babu has taught you. And once you have characterized, you will need very minimal imaging to diagnose and document. And that's it. Thank you.
Vishali. She really highlighted several points actually in the initial stage of diabetic macular edema. On OCT, you can really define that center is getting involved and you need to have a strategy of management. When it is exactly center involving, then you should not do the lasers, anti-VEGFs or steroids, depending upon whether serous foveal detachment is not there or not. And she highlighted that on OCT, if you are seeing a bilateral serous foveal detachment, you should investigate for nephropathy. Either microalbuminuria also should be ruled out. If you see the FA, again, what Brijesh asked, we have clearly told you when to go for FFA. When you are definitely in doubt, it's always better not to hold and get the FFA done. But one thing I want to ask you, Vishali, is the systemic control. You said that any diabetic macular edema, when it is present, you would like to control the systems and then decide the treatment. How long would you treat before you say that I will go for the treatment, or you will start the treatment and then expect the patient also to control the system simultaneously?
No, it's working. What Dr. Kim showed the study from our department, where we had initially said that we wait for 4 to 6 weeks to get a good control and then treat. That is pre-anti-VEGF era. At that point of time, the only treatment was laser. And if you do laser when there are a lot of hard exudates, they all tend to come in the center of the fovea and form a scar. So we were not doing laser before systemic control. Now we are in the era of anti-VEGF. So we start these two processes simultaneously. We ask the patient to get the systemic control for lipids, for microalbuminuria, for anemia. And one important thing about anemia, like Dr. Babu and Dr. Kim highlighted, our patients have nutritional iron deficiency anemia most of the time, so endocrinologist has to be involved because traditionally they used to keep hemoglobin a bit low because of the erythropoietin induced, but our diabetics many a times have iron deficiency. All that is controlled, but we do not really wait for parameters to come back to normal before we start injecting. We just inject following AIOS guidelines. If the fasting blood sugar is less than 200 and there is no contraindication, we start injection simultaneously.
Yeah, another important thing is that certain times when you want to control the systems, if you are injecting, certain times patient take it very lightly. You take some time, ask them to get the investigations done, maybe 1 week or 2 weeks, so that he will get into the seriousness of systemic control. Then you inject and simultaneously tell him that unless your systems comes under control, your eye condition not going to improve. This is very, very essential.
Yeah, but that is applicable only if it is non-proliferative.
Yeah,
Because in
obvious,
our own
obvious.
center, you know, some of the residents, even with the NVD, were referring for systemic control. So I think it's very important to,
Exactly.
you know.
Yeah, she highlighted very well. Actually, in diabetic macular edema, which is not very urgent, you can adapt that process. But in proliferative, especially high-risk proliferative, you should not wait, simultaneously go for both the things. Yeah, now I will invite Dr. Ajay Arora. He will be speaking about lasers in diabetic retinopathy and DME, and also how to manage the recurrences. Dr.
Thank
Ajay.
you, Dr. Babu. So thank you for including me in this course. And Dr. Babu, Dr. Vishali have been actually guiding in my retina journey. Before I start my presentation, just 1 or 2 points which have already been discussed I want to highlight. One is in the study, the Ascent Dream study, what is most concerning is that in Indian population and what was published in 223, the ICMR data, they analyzed patients of diabetes above 20 years of age. And in India, the people who are affected are less than 40 years. So these people are highly likely to develop diabetic retinopathy, and that is very, very disturbing. And other thing which was pointed out was the South Asian phenotype, which is typical of Indians who are non-obese and yet they are diabetic. So that is also very, very disturbing, but that's the way we are, that's what our genetics is, and that's what I think we should control on. So thank you for the invite, and can I have my slides, please?
Yes.
Yeah, so I'm talking about lasers in diabetic retinopathy and DME, management of recurrences. So Mark Twain, once when he had expired, he was still living, and reports of my death are greatly exaggerated. Lasers too are not dead; they remain relevant in the management of diabetic retinopathy even today. So what my plan of presentation is to talk to you about the standard 80 AIOS protocol, the modified 80 AIOS laser, the modified macular grid, plan for focal laser for recurrences, use of subthreshold micropulse laser, and use of lasers beyond the equator for the persistent macular edema and in cases of recurrent vitreous hemorrhages. So the diabetic retinopathy study demonstrated that there was a 50% reduction in the rate of severe visual loss in patients treated with pan-retinal photocoagulation, and prompt laser was necessary in cases of high-risk PDR. ETDRS told us about the relevance of treating the macular edema and also showed us that in cases of severe NPDR, scatter laser could be considered. Aspirin had no role. And this is a slide of 2006 when we were going after the red lesions, when there was a focal hyperfluorescent spot on a angiogram, and we were trying to precisely laser them. We don't any longer do it because they lead to scotomas. We were doing a grid laser for diffuse diabetic macular edema, and then we had a modified grid laser which came up after that. But we were happy treating them and ending up with a flat macula with a paracentral scotoma when these people will have difficulty in reading, but we were happy with it because we did not have options available, which is the pharmacotherapy, but not any longer. So then came up with the drcr.net study and the European expert panel, which clearly said, and Dr. Vaishali has pointed out, that center involving diabetic macular edema must be treated with pharmacotherapy, and an extra foveal macular edema with a focal edema should be treated with laser. So this is what we do for the focal edema. And if you have a patient who has an edema which is about more than 500 microns from the macula, which we were treating after this report. But personally, I would follow these patients which are more than 750 microns. So this is another patient who was treated with focal macular edema. So these are the various types of macular grid: the diffuse grid by ETDRS, a modified ETDRS, and the mild macular grid photocoagulation. In the mild macular photocoagulation, the microaneurysm is not directly lasered, while in the modified grid, the microaneurysm is just you turn them into a light gray, and for the focal edema, it is definitely useful. Now, in case you have treated them, how do you treat a recurrent macular edema? So there are certain rules for that which have been said. A persistent or a residual CSME after 3 months, or new residual areas of thickness, you can take the treatment up to 300 microns. That is what was recommended by the ETDRS. And always when you treat, you must do an angiogram. But this is no longer done. I would prefer to be outside 750 microns of the foveal center. And if on the OCT I find a thickness of 450 microns or less, I tend to do personally in my patient a subthreshold micropulse laser. Like for example, this particular patient who had a macular edema which was extrafoveal with a visual acuity of 6.9, we went ahead and treated this patient with a subthreshold micropulse laser, and the patient responded well. Another patient who had an extrafoveal edema before cataract surgery, it's extremely important not to operate them for cataract till you have handled the macular edema. So we treated this patient again with micropulse laser, and subsequently was taken up for cataract surgery. The patient did well. We have other lasers like a Navilas laser where the fovea is protected, the other lesions are marked out, and a laser is done. So by a careful planning, Navilas laser can automatically treat these patients. And the advantages is there's a clear-cut guidance how to treat them. There's a protection of vital structures. The eye tracking is fed in, and there's a digital documentation. We have cases where we have treated, this is a 61-year-old male who is a type 2 diabetic, hemoglobin A1C was 8.6, treated with anti-VEGFs, but was persistent diabetic macular edema. You do a angiogram and you find there's an large area of capillary non-perfusion in the periphery, and we have NBE. So this person is not going to respond. You will keep on injecting anti-VEGF till you start treating them, and once an additional PRP is done for these patients, so here the laser has been done, and you might have some cystoid changes left, but the patient responds. In cases of panretinal photocoagulation, you must split your sittings into multiple sittings, and if you do excessive laser, you might rarely end up with a choroidal detachment. Now here I'll show you 2-3 cases how laser has helped us in treating cases of recurrent vitreous hemorrhage. So this was a gentleman who went ahead with a vitrectomy with fluid exchange, siliconal injection, subsequently siliconal removal was done, and patient had a recurrent vitreous hemorrhage. We waited for some time, gave an intravitreal anti-VEGF, and then again, patient had a repeat bleed. Patient was taken for the vitreous lavage, fluid gas exchange was done, and at that stage, after the fluid gas exchange, we did a wide field angiogram. And we found that in the periphery, it was not completely lasered. We had done just beyond up to equator. There were areas of NV, there were large areas of capillary non-perfusion. These areas were subsequently treated well. And for now we have waited for almost 21 months. Patient has not had any fresh vitreous hemorrhage. His other eye, which was treated, we had done an angiogram before the vitrectomy, treated these peripheral areas, and patient did well. So there's multiple other patients where if, in such a case with so much of laser, I would not expect any more NV, but yes, there were NV and patient was having small recurrent vitreous hemorrhage. We treated this and patient responded well. If I did not have a wide field angiogram, I would not be able to detect them. So that is probably the utility of wide field angiography. The same patient in the other eye, we found large areas of capillary non-perfusion and patient did well. So this is, I've had a few interesting cases. This is one of them who is, whom I have told about subthreshold micropulse laser. So I have treated his macula with a 5% duty cycle micropulse laser and the periphery with the micropulse PRP with a 10% duty cycle. I have a 3-year follow-up on this patient now. He has had multiple sittings, over about 3 sessions of micropulse PRP in last 3 years. He's maintaining his fields. Whenever he gets a small NV, we treat them with a normal laser, but the other areas we treat them with micropulse, and we are able to maintain. So this could be an option. I'm in practice, so I can't do an institutional study, but that should be an option. So the take-home message for diabetic macular edema is I would treat a patient with laser when it is beyond 750 microns. So the laser photocoagulation was relegated to the backyard with the advent of pharmacotherapy now, but with a better understanding, it's making a comeback. Panretinal photocoagulation remains the cornerstone of PDR treatment over last 4 decades and still is relevant. Ultra-wide field angiography has helped us in identifying NV and CNP areas, and this could be an answer for the recurrent vitreous hemorrhages. Laser photocoagulation is the best way to treat focal extramacular edema, and subthreshold micropulse laser used judiciously may be an effective way to treat diabetic macular edema and probably reduce the load of pharmacotherapy. Thank you.
Thank you very much. You're on time. Very good. So we now move to the lasers because many youngsters only very comfortable with injections. But believe me, diabetic macular edema is a chronic disease, and certain times injections may not be the answer for a long-term basis. So there are certain subsections of diabetic macular edema and PDR, obviously. Laser plays a major role. In this, you have covered very well about the lasers, where exactly you need to do all the areas and when to select laser. Definitely, we will not do the center involving diabetic macular edema. You consider injections apart from systemic control. However, there are indications. If you see there are leaking areas are there, okay? With diabetic macular edema, where the majority of the leaking areas are between 300 to 500 microns. What is the strategy you will apply?
So I have 2 strategies, sir. In case there is an associated macular edema on the OCT, I would probably go for the pharmacotherapy.
It is there. It is
If
there.
it is, because I now no longer go closer to 500 microns, so I would rather give an intravitreal anti-VEGF
Why would you?
And if the thickness has come down to 450 microns, I have a micropulse laser available, and if it is a diffuse diabetic macular edema, then I would give my micropulse laser. If it is a focal lesion, a single microorganism or 1 or 2 microorganisms which I can handle, then I'll take a 50 micron spot and probably treat them without making a very, very gentle gray lesion, because it might help.
You need to be very, very careful in doing laser in the near to the macular center, between 300 to 500, even Beyond also, I would be very, very careful in that because what we have observed is over 5 to 10 years, the spot you have given spreads and the scotoma can be certain times disturbing. So that's why committing for a laser, what you have done a small spot today can be enlarged and it can become a bigger spot. That's what
Yeah.
makes
And
you
these
hesitant
patients
about.
must have a good metabolic control. Because
Yeah,
that's
obviously.
always
Obviously.
very important.
No, no, that we have already covered, and we will say that good systemic control, injections you have given, but still one or two leaking areas which are prominent, but it is between 300 and 500. Certain times that alerts you and it will scares you also to do the laser, so you need to be careful in that. And another important aspect is only don't go for macular edema by repeated injections. There is a peripheral CNP errors. This is very nice point which he has highlighted, that by treating them, you can reduce the recurrent diabetic macular edema, which is very, very good. And excess laser, what would you suggest for all the delegates that how to tackle that you will not do a excess laser so that the complications will be much more, even a deep laser or excess laser. Both the things can lead to complications. So what are your suggestions?
So there are very defined way which have been said as to how do we space our spots, what should be the lesion color when we give. If it is white color, it means it's almost involving the entire retina. So it should be a gentle gray color. Initially, we spread out depending upon the, Dr. Vishali asked a very important question when Dr. Babu was presenting, that how do you assess clinically? Do you sit down and count those 20 hemorrhages? Similarly, I think we are able to assess what is the severity of the disease. So sometimes we might space them 1 burn apart or maybe half a burn apart. We do not go closer than that. And sometimes later on, patient comes back to us. So I personally, for myself, on a diabetic patient follow-up, if the patient comes back to me after a year, I would repeat an angiogram in these patients because I may miss neovascularization. So I tell them that once a year, if you are stable, I would like to do a fluorescent angiography. Since I have wide field, I do it now, and then I laser them. Sometimes you have to augment our PRP once we do an angiogram. So this augmentation, you'd call it a fill-in PRP, and we do it whenever it is required.
Rather than saying once a year, I would say that if there are any alarming developments on examination, then probably we will commit for angiography.
Yes, sir.
Rather than saying once a year. With this, thank you very much, Ajay. And now I invite Dr. Rajiv Raman. He will be presenting about role of anti-VEGFs and steroids in proliferative as well as diabetic macular edema. Please. Thank you for Yeah, can you project Dr. Rajiv Raman's slides? Yeah. Rajiv.
Thank you. Thanks for having this every year instruction course. I really love being a part of it. And next couple of minutes, I'll be sharing views on the role of anti-VEGFs and steroids in proliferative and diabetic macular edema. The first few slides are more of a revision of what we have learned. Can you go next? I'm not able to. It's not
Can you
working.
see the
Yeah. So there are certain guiding principles for treating macular edema. We'll first tackle diabetic macular edema, then go to proliferative disease. So as we have learned that though it's important classification of macular edema as a clinically significant, today we classify it more as a center involving or a non-center involving. The glycemic control, control of blood pressure, lipids, anemia, all are very, very crucial whenever we are dealing with macular edema. And anti-VEGFs are the first line treatment for CIDME. We switch anti-VEGF, switch to a laser or steroid if it's a non-responder. And the two tests which are very crucial in determining the initial treatment choice and even on follow-up the response of treatment are OCT and visual acuity. It's the best corrected visual acuity, not only the distant but even the near vision. In case of vitreomacular traction and select cases of non-responding diabetic macular edema, vitrectomy does have a role. So that's what the algorithm is all about. So you start classifying it as non-center involving or a center involving. Very recently, last month, we have published that 2 years, if you take a non-center involving and follow them up, a third of them will convert to a CIDME. And the only risk factor is more duration of diabetes. So more than 10 years duration, they are the people who have more risk. Either you can observe or you can even do a focal or a grid. If it is center involving, you look into the vision. If vision is good, like better than 6/9, and the patient doesn't have any symptoms, very elegantly the DRCRNet protocol has taught us that we can watch these patients, no need to treat. However, they have also identified subgroups which can worsen, so to be a close watch on these patients. Vision is poor, anti-VEGF you start with and treat it, and after 2-3 injections, every injection actually you should see how the response is. And if it is improving, you continue with anti-VEGF. If there is less response, you have other strategies to do. Now, as I told you, diabetic macular edema is not a generalized algorithm. There are many patient-related factors which alter the treatment. So if a patient has a recent history of a cerebrovascular event, less than 3 months, these are the ones where you tend to avoid anti-VEGF. You can consider steroids. You can even consider laser. If you see a pregnant lady with diabetic macular edema, it's a very mild edema, good vision, you can watch. Early in the pregnancy, you can think of, and if it's a severe edema, laser, steroid, both are option. However, if the lady comes at the late pregnancy, you don't treat because majority of them will spontaneously recover. If a patient is of poor compliance, again you can consider intravitreal steroids or laser rather than thinking anti-VEGF as the first choice. And if a patient has chronic kidney disease, renal condition associated, you start with anti-VEGF. However, on treatment, besides looking at your macula, also see the eGFR. And if you feel that the eGFR is worsening, you can skip an injection in that visit or switch to steroid. There are certain eye-related factors which also govern the treatment of DME. So if it's a vitrectomized eye and having diabetic macular edema, because the vitreous sump is gone, anti-VEGF may not last for a longer time and steroids become an important one. However, if you are treating with anti-VEGF, do tell the patient he will need more number of injections. If it is diabetic macular edema with proliferative disease, anti-VEGF becomes the first choice, and you do either a same time panretinal photocoagulation. Traditionally, we used to treat only the nasal part, assuming that the macular edema will increase, but with anti-VEGF, we can complete the PRP, or even you can do a deferred PRP. If it's a pseudophakic eye with diabetic macular edema, it's important to definitely differentiate a pseudophakic with diabetic macular edema. Majority of time you'll have both the components, and you can consider steroids as one of the treatment when you have a pseudophakic eye with diabetic macular edema and or pseudophakic edema. There are certain disease-related factors which can play a role. So sometimes you have this plaque of hard exudates, and these are the ones, as Dr. Kim mentioned, have severe dyslipidemia, so definitely it's important to control it. Intravitreal steroids, they tend to have a little better role in clearing these exudates. However, you must realize that even with that, the vision hardly improves, because once you have this plaque, invariably you will have an area of RP atrophy. And definitely adjuvant lipid-lowering drugs are important. If it's a very poor vision, thicker retina, you tend to go with these newer drugs, aflibercept, and now we have the faricimab. You can think of using those. And when you have these vitreoretinal surface abnormalities, the anti-VEGF response is a bit poor. Though they respond, again, you have to counsel that they may need more injections. However, if there is a frank traction, nothing will work. Vitrectomy in these cases definitely is a solution. Now we have many newer agents for treating diabetic macular edema, and all of them are looking at improving the efficacy or improving the durability. Efficacy is more reduction of central subfield thickness, more improvement of BCVA, early resolution of edema, and having less non-responders. And durability is more longer duration of injection-free period, minimum recurrences, less injection visit, and less monitoring visits. And the newer drugs, like now we have faricimab, and we'll soon get the Eylea HD, the 8 milligram aflibercept, they will be probably one which will be increasing the durability more. Switching gears to the next, the proliferative disease, still laser panretinal photocoagulation is the mainstay as far as treatment of PDR is concerned. This were the classic diabetic retinopathy study, and very nicely it had shown that it reduces the risk of severe vision loss by more than 50%. And they went ahead following these patients for much longer period. So we can see more than 15 years, the same cohort of patients of diabetic retinopathy study, when they followed, they still found that 42%, they still retain 20/20 vision. So definitely laser is not the early, even after 20 years, it is showing its effect. And 84% retained 6/9 vision or better. So we also tried looking at what happens in Indian population, and we had this big cohort of people who had PRP, and we followed them more than 10 years. And we found a similar results. Nearly 57% of them had a better than 6/12 vision. And we also tried looking at how many of them needed vitreous surgery, only 1/3 of it. So definitely PRP seems to work well. There is no substitution for panretinal photocoagulation. It's a 20-year follow-up. So definitely it works well. So after 3 decades, is there any need for change as far as that PDR is concerned? Yes, we think that can we have better anatomical outcome than what, because seeing this type of a picture and seeing a retinitis pigmentosa with lot of pigments in the periphery, both look similar. So definitely if we can have a better anatomical outcome, can we have a better functional outcome? Can we have less adverse effects or probably less progression of the disease and more economical? So let's see whether anti-VEGFs could achieve that, because there are a lot of trials which came showing that it can be used for proliferative disease. So the 2 major trials were the Protocol S and the Clarity study, and they did find, if anatomically Protocol S 5-year follow-up found that it's same. The risk of the neovascularization was similar as just 2 minutes more in both PRP and this, and Clarity anti-VEGF had more neovascular regression. Functional, to the surprise, we thought fields would be reduced in PRP, but field loss was seen even with anti-VEGF. That means disease still progresses, the CNP areas still continue to form, and they cause the scotoma. Side effect rates were similar, progression also it is similar. So definitely, and cost, we know injection cost is much high, so probably anti-VEGF is not an answer. And the major concern is the loss of follow-up, and in Protocol S only 60% came. And they did a subgroup analysis to find out those who were lost to follow-up, what happened to them, and they had poorer vision, they had more patients with tractional retinal detachment, and they had more rubeosis. So you must keep in mind, if you have a very compliant patient, a very mild disease, and you are thinking of using, I have a couple of patients on monotherapy, on anti-VEGF, all these criteria, definitely think of using a lone anti-VEGF, otherwise definitely PRP is the solution. So just to summarize, diabetic macular edema, anti-VEGF still is the first line of drug. Steroids are effective, but are in a very selective group. The newer pharmacotherapy are all increasing the durability, and we will see soon our patient visiting us less often. PDR, PRP still is the mainstay of treatment. The patient selection is crucial if you are considering anti-VEGF as monotherapy, and definitely there is role of, I've not covered, before diabetic vitrectomies, we do give anti-VEGF, it has got a definitive role. Thank you very much, and I would like to invite all of you for the 6th Retina Summit which is on with ROP in July 2024. Thank you very much.
Thank you, Rajiv. Please wait. Can Dr. Sangeet can come and start his first slide, probably. In between, we will ask you some questions. Please. Yeah, the one thing which it is very clear, and this thing really it do not require any further clarifications. But I want one area where you said early nephropathy and anti-VEGF avoidance. Can you a little bit more clarify
So
about it?
this came, I think, in 2022. There was this nephrologist. So there is no evidence. It's more of a consensus statement from the Nephrology Association, which suggested that if you use anti-VEGF, it can, like regular use can reduce eGFR. And they suggested that probably the newer drugs or alternative drugs can be used. So there are no evidence as such suggesting that eGFR reduces. But if on treatment you feel that the nephropathy is worsening, it's not a bad idea to give a gap, take more, because even we know that we want to control nephropathy for diabetic macular edema.
Yes.
So not a bad idea to give a gap and then start again.
You say regularly GFR should be done, or you want
I
any
told
other
eGFR.
parameters?
eGFR is estimated GFR. For that you only need a serum creatinine.
Yeah.
So serum creatinine, if you have done, you can calculate a eGFR, and that is, so this was again one study with Dr. Mohan we did, that if you are dealing with diabetic macular edema, it is the albumin creatinine ratio, that is microalbuminuria becomes more important parameter. In proliferative disease, it is the eGFR, which is something which you must monitor.
Any level would you suggest that people should be careful about it?
It's not the level, because eGFR is used to classify the chronic kidney disease. So less than 20, so you don't want them to go down, because they will change from a mild moderate CKD to a severe CKD. You don't want that to happen.
Thank you very much, Rajiv. Sangeet, can you start your presentation now?
Thank you, sir, and I thank you again for this, making me this part of this course for the first time. And I'll be speaking on surgical management of diabetic retinopathy. And before proceeding further, just a brief review of what is the surgical anatomy in diabetic retinopathy. We all know that new vessels grow along the arcades using posterior hyaloid as a scaffold, and then they progress to fibrovascular and contractile epiretinal membranes. And these membranes again grow and contract to give rise to tractional retinal detachment. And increasing traction, with increasing traction, the breaks develop and they lead to combined rhegmatogenous and tractional retinal detachment. And if this traction is more on retinal vessels, those retinal vessels may rupture and cause vitreous hemorrhage. And it is difficult to treat these membranes, and the difference from the retinal detachment is basically that these membranes are not glued and you just can't pull on these membranes, but they are sort of nailed at multiple epicenters of neovascularization. And you have to go around those new nails to remove all this growing tissue. And various indications for vitrectomy in diabetic retinopathy include non-clearing vitreous hemorrhage, macula-threatening tractional retinal detachment, combined retinal detachment, neovascular glaucoma. In early stages, when you have to do removal of vitreous hemorrhage earlier, severe PDR when your diabetic retinopathy is not responding to your pan-retinal photocoagulation, and there's still growth of new vessels even after doing maximum pan-retinal photocoagulation. Subhyaloid hemorrhages, you have to go in early. And in diabetic macular edema, whether it is recalcitrant, tractional, or subfoveal hard exudates are present. So the various goals or the various steps of doing vitrectomy in diabetic retinopathy include, first of all, is like to clear the media opacities. This video is not playing. Yeah.
Can you address the issue of video not playing?
Yes, now it's. So first thing is like to clear the media opacities, you remove all the vitreous hemorrhage or the subhyaloid hemorrhage, and once these media opacities are clear, you get a good view, then you create a plane of dissection. I prefer to start my dissection at the optic nerve head, just remove the membrane from the optic nerve and you get a good plane of dissection. And you proceed with the dissection of membranes, you cut around all these vascular epicenters one by one. You can do desegmentation, like one by one you remove all these membranes, and delamination. And with the cutter you can do both the things at the same time. And then if there is a tractional retinal detachment or combined retinal detachment, you have to settle the retina, then do ILM peeling if it is needed. Laser the retina, give a good photocoagulation to prevent recurrences of vitreous hemorrhage after surgery. And in the end, you give a tamponade. And you have to be wary of the vitreous cases which may be present in these eyes, which is very common. And after you have to remove all the membranes and identify all the membranes before you close the case. So coming to the vitreous hemorrhage now, we do mostly in non-clearing vitreous hemorrhage, though the DRBS recommended 6 months waiting period. But nowadays with the better instrumentation and better machines, we are now going in early. Some surgeons prefer to go as early as 6 weeks. But if there is a concomitant RD or a new vascularization of the iris, or it's a type 1 diabetes mellitus or subhyaloid hemorrhage or a hemolytic glaucoma, you need to go in early. And this is how in vitreous hemorrhage, in severe vitreous hemorrhage, you make a hole in the peripheral vitreous and then you remove, this is called a skirting technique. Then you just proceed either posteriorly or circumferentially, just keep on enlarging the hole all around. And this way you can remove all of the vitreous hemorrhage without causing damage to the underlying structures. So here, simultaneously, I'm moving posteriorly as well as I'm going circumferentially. So once this hole is created, then you are safe, you know what is lying below, and you can slowly increase the perimeter of your cutting. So this is what is called the skirting technique. And sometimes you will have the subhyaloid hemorrhages, and the trick is to just make a small hole here posteriorly, and through this small hole you try to remove all this hemorrhage, all possible hemorrhage, because if you make a larger hole here, the whole of this blood will come into the vitreous cavity and will impede your view, and you'll have to spend a lot of time clearing the media after this. So through a small hole, remove all this blood, and then you proceed ahead with your surgery. So for retinal detachment, especially in the TRD threatening the macula or the combined retinal detachment, one thing we often use is for this largely vascular membranes, we give a anti-VEGF 3 to 4 days before routinely. And this was the patient who went anti-VEGF 1 day post-operatively, and you see the membrane vascularity has decreased markedly, and you can proceed with your vitrectomy without any fear of bleeding during the surgery here. Again, you can see you segment this new vascular epicenters one by one, and you keep on dissecting them one by one. Also, you can use the proportional reflex, which is present nowadays in the vitrectomy machines, to elevate these membranes and create some space for dissection. Here I'm using this proportional reflex to just create some space and then dissect these membranes. This is the post-op, and this is another patient with combined retinal detachment. Again, in this patient, I just went ahead, created a plane of dissection by removing the membranes at the optic nerve head, and then I created a wedge connecting the central retina with the peripheral retina, and now I am inducing the PVD in the peripheral retina, and this way you can go from to remove the membrane from all the sides, and it becomes easier. So what I generally do, I call this around the table dissection. So from both sides you can take up the membrane, not inside out or outside in. In this way you can go both outside in and inside out whenever you please to do it. So this is 1 year post-operative, the same patient. Bimanual peeling is very helpful in very thick and highly vascular membranes in thin retina, or if you're not able to start your membrane dissection at the disc. And for this, this was a 46 years male. Female best corrected vision was hand movements. She was one-eyed with PDR and tabletop TRD. Again, my method of doing bimanual dissection includes I generally use a homemade chandelier. I remove this metallic strip over the old light pipes, and then I cut this is stripped off, and then it is cut from the middle, and then it can be used as a chandelier. And this is the same patient how we proceeded for surgery. I for my way is using a longer 1-inch 25 gauge needle, and you can just hold up the membrane, and with this needle you can cut at the vascular epicenters, and similarly this can be used to delaminate the membrane as well. So one by one all these vascular epicenters were removed. And once you reach the optic disc, you know now that you can remove the membrane from the optic disc and proceed further with your vitreous cutter or with the scissors if you may like as such. So this way with the needle, I now, when you have some difficulty, you can use either a scissor or a cutter to cut these membranes, but this is what you do, but you do whatever you feel like, but one by one, all these vascular epicenters need to be removed. So this is the 3 months post-operative, the best corrected vision had improved to 6.9. Coming to diabetic macular edema, we generally do vitrectomy if your diabetic macular edema is not responding to your traditional treatments, or as Dr. Vishali pointed out, in patients with retractional macular edema or with taut posterior hyaloids. Some people have advocated using a primary vitrectomy for non-tractional DME also. And if you have very high plaque-like soft oval exudates, so these are some pre and post pictures of vitreomacular retraction. You did a vitrectomy and the patient settled. This is a patient in which there was an epiretinal membrane in a diabetic case, and you have to do a vitrectomy as a primary procedure here. And this is the patient with diabetic macular edema with subfoveal exudates, in which the exudates were increasing despite multiple injections. And in this, the vitrectomy was done and the patient improved. Thank you, sir.
Very much, Sangeet. Actually, it is very clear and crisp. One message clearly we want to send is what cases you had showed as a before surgery. Some may think that it is not doable.
What, sir?
Some may think that it is not doable and they may explain the prognosis. I urge all the delegates that they should refer these cases to at least one of the vitreoretinal surgeries. And a lot of cases where you think it is end stage, it is not really end stage, and we can still revive the vision in these patients. Thank you for showing that very clearly. We have two issues which during our all presentations which were not addressed completely is one, diabetic retinopathy with vitreous hemorrhage.
Yes.
Where a lot of people tend to inject. The patient comes and I was advised injection. Vishali, can you highlight when to inject? If you are injecting, how to follow these patients?
I think if there is a vitreous hemorrhage which is dense enough, yes, 1 minute.
Almost over. Yes.
Done. And you cannot visualize, injections is not going to help. If it is previously lasered patient and you can see the part of retina nicely and it's just the mild to moderate vitreous hemorrhage, then injection might help. And if it is not lasered mild hemorrhage, you do inject, but then you have to do laser promptly as the hemorrhage resolves.
Thank you very much.
One
Vishali,
more indication I would like to say is that vitreous cavity hemorrhages, if you are having recurrent, you can use injection as a good option in those cases.
That is just a temporary option, not as a permanent.
You can, so you can do as a treat and extend.
Yes,
you can
yes.
keep on injecting and extending the treatment. And
Yeah. Yeah, thank you very much. We should conclude here because we are little overshot the time. I thank all my instructors for this instruction course, and the attendance was good in spite of the hall accessibility is a little bit difficult, but once we know the target, we can reach the way. Thank you very much. And I request all the instructors for join for a group photograph. Thank you.